Hello, this is Dr. David Keast, and I'm pleased to report to you some of the work we've recently done looking at the relationship between lymphedema, body mass index, and socioeconomic status. The site of our research is at the Parkwood Institute Research in London, Ontario. I need to initially state that we have no support from any commercial organizations, and there is no potential conflict of interest with this particular material. If we look at the context in which we did this work, we are reminded that over 1 million Canadians suffer from chronic edema lymphedema. There are known risk factors which include cancer and its related treatments, obesity, chronic venous disease, immobility, and several other risk factors. A previous study that we did of 326 lymphedema patients demonstrated that 45% of them had body mass indexes greater than 30. Little is really known about the impact of socioeconomic status that might have on lymphedema and people living with obesity, period. We are reminded, of course, that socioeconomic factors include income, education, and occupation. We chose to look at income. The object of our study was to conduct a preliminary study of the potential relationship between socioeconomic factors, body mass index, and lymphedema. The study was set up by looking at an administrative database that is maintained through our chronic wound management outpatient clinic. Records of lymphedema patients who had been seen in the Parkwood Institute from 2011 to 2020 were accessed. Data were de-identified. What we did record was the first 3 digits of their postal codes. We then looked at Statistics Canada data from 2016, looking at the mean household income by postal code. A subset of data also looked at body mass index equal or greater than 30. Just to be clear, these are the definitions of obesity that we used. Less than 18 was determined to be underweight, and a body mass index greater or equal to 40 was listed as class 3 obesity. So what results did we find? Well, 728 charts were reviewed with patients identified as having lymphedema as their primary diagnosis. Of those 728 patients, they came from 94 different postal codes. Approximately 60 of those postal codes represent London, Ontario. So that was 414 patients from London. The remaining 314 patients came from mostly southwestern Ontario, from Windsor to Toronto, and from Tobermory to Lake Erie. A subset of patients, 337 of them, had body mass indexes greater than 30. This represents 46% of the total, which is consistent from our previous data from the 2015 analysis. Overall median household income peaked at $58,000, which is less than the related median household income from the Greater London Metropolitan Census Area of $64,743 obtained in 2015. When obesity data are matched to income, there appears to be clustering. When we look at the obesity rates on this current group of 728 patients, we find that over 40% of them had class 3 obesity or greater. When we looked at the distribution of household incomes, the graph demonstrates this, where the y-axis is the number of patients living in households with incomes as listed on the x-axis below. And as you can see, it peaks in the region of $48,000 to $64,000 a year. Now when we do a scattergram, and at that particular point we look at median total income per household versus body mass index, we can see that there is indeed clustering of the results, and it appears to be at the lower income levels, somewhere around about $60,000 or less. You can also see the body mass indexes, of course, start at 30 because we did not look below that, and they peaked up at around about 80 to 100. So there is a possible association between lower socioeconomic status and lymphedema patients who have a comorbid condition of obesity, period. We do know that lower socioeconomic status is known to be associated with increased obesity. Further study is really required to delineate this better. Overall, we would comment that determinants of health need to be considered when developing care plans for persons with lymphedema. And this suggests that the possibility of managing obesity may help to reduce the prevalence of lymphedema in this particular group.
Thank you for joining today. My name is Manraj Kaur, and on behalf of my team, I'll be presenting results of a Canadian-made and Canada Cancer Society-funded patient-reported outcome measure for arm lymphedema, known as the Lymph-W. I have no disclosures to report. Just before we dive in, what are patient-reported outcomes? So patient-reported outcomes are key indicators of a patient's experience of a health condition or outcome of a treatment. These include things like symptoms, emotional well-being, appearance, social function, or even like overall quality of life. And if you think about these a little bit, it becomes quite obvious that these are the things that can only be known by asking the patients directly, or sometimes their caregivers, but not by patient observation, physical examination, or any lab or radiological test. Patient-reported outcome measures then are the instruments that are designed to measure patient-reported outcomes as directly reported by the patients without any interpretation of their responses by clinicians or anyone else. A recent systematic review of patient-reported outcome measures in lymphedema highlighted that even though the use of PROMs in lymphedema is increasing, there is no single PROM that rigorously assesses everything that matters to women with lymphedema and has been validated in this patient population. And hence, to fill this gap, the Lymph-W program of research was designed. It is a collaboration between 3 different countries, Canada, US, and Denmark. And as I mentioned before, it's funded by the Canadian Cancer Society. We used a 3-phased approach for this program of research. In the first phase, we asked what matters to women, and based on that data, we came up with preliminary versions of the scale. These preliminary versions of the scale were tested in phase 2, where we tested these scales for their psychometric properties of reliability, validity, and responses. In phase 3, which is currently ongoing, we asked the same question. So we still assess the same measurement properties, but we do that in independent clinical samples. So, women from different parts of the country, different countries, and seeking different types of treatments than that were included in the phase 1 or phase 2. In terms of phase 1, when we ask what should we measure, what matters to women, it's also a multi-step approach. So for the first step, which is the semi-structured interviews, we conducted in-depth interviews with women from 2 countries, Canada and Denmark. All of these women had breast cancer-related lymphedema and varied by age, stage of breast cancer, and type of treatment. These interviews were audio recorded and transcribed verbatim. During the interviews, we really dug deep and asked questions about progression, onset and progression of lymphedema, treatment and recovery. We asked about impact on physical well-being, impact on appearance, impact on psychological well-being, sexual well-being, social well-being, any financial impact of lymphedema care. Experience of care was asked in terms of satisfaction with the information that was provided by the healthcare providers. Women were free to bring forward any other concerns, and at the end of the interview, they were asked, out of the concerns described, which ones were most or least important to their experience. All of these interviews were coded using line-by-line approach. It will become clear in a few slides what that means. Were coded by 2 independent researchers, and constant comparison approach was used to refine the codes. So we had a total of 15 women with breast cancer-related lymphedema who participated in the first phase. Most of these women were white, married, had had mastectomy, which is full removal of the cancerous breast. About 50% of the women had had chemo, radiation, and endocrine therapy. So to illustrate how the line-by-line coding approach, I would like to use this quote from the participant. So she says, when you are, meeting somebody or talking to somebody and they're staring at your hand or your arm because it looks a little strange, or you have a glove or a wrap on it or whatever it is, I don't know. It's not pleasant to deal with. It just makes me not want to go meet people. So when she's saying that people are staring at her hand, we coded that as feeling self-conscious. She talks about how the arm, or the with or without the sleeve looks a little strange. She talks about how it makes her feel emotionally, so it's not pleasant to deal with. And overall impact of this is that she wants to like stay home and not want to meet people. So there's impact on social well-being as well. We did this across all the interviews, and we came up with 5 main Lymph-Q scales that measured symptoms, function, appearance, life impact, and information. These scales were shown again to participants, and feedback on relevance, comprehensiveness, and ease of understanding was elicited using Think Aloud approach. These interviews were also audio recorded and transcribed verbatim. We also showed the scales to experts that included surgeons, oncologists, and nurse practitioner, and we asked for feedback on relevance and comprehensiveness of the scale. As a result of the feedback, we end up adding quite a few items to some of our scales, and we also came up with 2 new scales that measured psychological impact of lymphedema and satisfaction with arm sleeve. These preliminary versions of the scales were then tested in over 3,000 women in the US and Denmark, and psychometric properties were established using something that is called rash measurement approach. So the key advantage of rash measurement approach, for those who are not familiar, is that you're able to come up with unidimensional scales. So meaning a symptom scale will only assess symptoms, a function scale will only assess function, and the way the items in the scale are organized is that such that they map out on a ruler. So just as a ruler, one end it measures less of a concept and the other end measures more of a concept. Mobility is a really good example to understand the concept of ruler in terms of scale measurement. So for example, when you administer the scale, you would expect somebody who's dependent on a walker obviously scores low on a scale, versus somebody who's able to walk and talk at the same time, to do more than one thing when they're walking, compared to somebody who's able to go for a jog or a run. So we use the rash measurement theory approach. This paper is now published in an open access journal, and if you just type Lymph-Q upper extremity module, it should pop up. If you need a copy, feel free to reach out to me after the conference. So finally, we had these are the current Lymph-Q scales that have established measurement properties. So these are appearance, function, psychological, symptom, information, and arm sleeve. As I mentioned before, the advantage of using rash approach was that we were able to come up with scales that are independently functioning. So no clinician needs to use all of these scales at once. They can pick and choose whatever scale is more relevant to their practice, and each of these scales is scored separately, so they're able to really assess the change. During our consults, we also found that we missed to include 2 important concepts in the Lymph-Q program of research, and these were lymphedema worry, where women talked about being afraid of getting a cut or a scratch, being afraid of lymphedema getting worse, their arm getting bigger, and just something that is constantly dwells on their mind. And the second concept was impact on work, so where they talked about either modifying, stopping, or feeling self-conscious at work because of the arm lymphedema, and using several accommodations such as touchscreen technology, voice recognition software to compensate or accommodate for the arm swelling. So to overcome this gap, we've conducted 12 interviews to date, and the preliminary scales have been drafted, and now we are getting feedback from patients on relevance, comprehensiveness, and ease of understanding of those scales. So stay tuned for more updates on this work. Thank you for your time. If you are interested in using the Lymph-Q current validated scales, feel free to reach out to me or go on this website. It is free to use for clinicians and researchers. Thank you.
Good day. My name is Letellier, and I'm a kinesiologist, clinician, researcher, and lymphedema therapist. Today, I will be presenting about an axillary syndrome scoring system. I have no conflict of interest to declare. Axillary web syndrome, also known as cording, is principally associated with breast cancer, but it can also be seen in melanoma, where the axillary surgery is performed. It is a palpable and visible network of cords thought when the shoulder is abducted. Your patient will often experiencing a lot of pain, pulling in, and shoulder restriction when she's trying to do her post-op exercises. Therefore, axillary web syndrome may lead to severe impact on upper limb function, reduced range of motion, not able to perform activities of daily living, reduce health-related quality of life, and could ultimately postpone radiation treatment. Its etiology remained misunderstood. However, the latest evidence is showing that there's a lymphatic involvement. Axillary web syndrome is a common and important complication of breast cancer axilla surgery, where approximately 1/3 of patients will develop it, ranging from 6 to 86%. It usually develops within the first 8 weeks post-surgery, but it is possible to develop it in the long term, after radiation therapy, for example, or even months after treatments were completed. In addition, it can resolve on its own, but it could also relapse. Actually, patients experiencing axillary web syndrome are referred to rehabilitation services and all are triaged and treated the same without knowing its severity. In hospital setting, there's a need to qualify the urgency of an appointment for patient. Therefore, the objective of this session is to present a clinical scoring system developed in our MUHC lymphedema program to objectively assess axillary web syndrome. We think that this could help prioritizing the patients and see if there's any improvement with the treatment and the exercises that we provide. So the idea of creating a scoring system came after assisting to a conference. 3 lymphedema therapists reviewed the literature and consulted with a panel of lymphedema experts and developed a first draft of the scoring system. This was tested in our clinic, and after a few weeks of trial, some modifications were done and led to the second draft. The second draft was tested with 2 breast cancer survivors experiencing an axillary web syndrome. The first patient developed it 1 year after her surgery, and she did not have any limitation or it had a little impact on her quality of life. And the second patient developed it after a radiation treatment, and she had a lot of limitations and it was impacting her quality of life. So 7 healthcare professionals from various disciplines, all certified in lymphedema therapy, were invited to participate in a training and testing of the scoring system, and most of them had over 5 years experience with breast cancer patients. So here is the scoring system that we tested, and you have 9 categories on a total score of 25, where we thought that the final score could provide a stage and a severity of axillary web syndrome. The intra-rater reliability was excellent, while the inter-rater reliability ranged from good to very good. On debriefing, improvements to the original scoring system were elicited. So you will see in red the categories that requires improvement, and in green those that will remain as is. So the first category, diameter, it raised some issues, as in reality we use our fingers to feel the cords rather than measuring it with a measuring tape. So it was found that using millimeter to describe the cords were not consistent among the healthcare professionals. So in the revised version, it will be presented more as what we feel under our fingers as being fine, thin, or thick. So the category location was fine. However, the debriefing pointed that we were missing the endpoint of the wrist. That is looking at if a cord are felt either in the superficial or the deep hand. So if both are felt, only a score of 2 will be given to the deeper level. The category count raised also questions, as a thick cord can be felt in the axilla and, for example, 3 thin ones in the elbow. So the revised version will include a place to note the number of cords felt in each joint, and the score will be based on the maximum felt in 1 point. This category asks whether a truncal cord is present or not. As shoulder abduction is quite often affected when a cord is present, this category gives a higher score to the greatest impact on range of motion. It is important to know whether or not axillary web syndrome is impacting activities of daily living, as the person might be quite limited with the cord, but in fact, it doesn't really impact her daily activities as she drilled her spouse to do everything. Other category is the elbow restriction. So it's looking if there's a restriction or not. And last is regarding pain. So pain is one of the greatest complaints when you experience a cord. So a score of 1 is given when pain is present, regardless of its intensity. So in interpreting the result of the score, it was discussed and found more relevant to mention about the severity of the axillary web syndrome rather than giving it a stage. Therefore, it was decided to remove staging from the scoring system and only keep the degree of severity. To date, no scoring system exists to objectively score and triage the severity of axillary web syndrome and prioritize rehabilitation needs. As resources are limited, the goal in developing an eventual valid and reliable axillary web syndrome scoring system is to offer healthcare professionals a systematic approach to track the severity and progression of this condition, facilitating optimum and timely patient care. Due to the pandemic, everything has been delayed. So the next steps will be to reassess the validity and reliability of the scoring system with the proposed modifications. Also, in order to increase our knowledge of axillary web syndrome, some women will get their cohort investigated with high-definition ultrasound over time. Thank you for your attention.
Hi everybody, thanks for coming today. So I'm going to be presenting on a virtual arm self-measurement protocol our research group is doing to reduce development of upper extremity lymphedema after surgery for breast cancer. I'll be going through the protocol as well as sharing some preliminary results. I have no conflicts of interest to disclose, and I want to start off by acknowledging that I'm joining you today from the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh First Nations. I also want to acknowledge this work is being conducted across the Fraser Health Authority, which is on the traditional, ancestral, and unceded territory of the Coast Salish and Inkla-Pamux First Nations. So, as a bit of background, about 1 in 8 Canadian women will be diagnosed with breast cancer in 2021. Treatment typically consists of surgery, chemotherapy, and radiation therapy. Collectively, these treatments can disrupt normal lymphatic function, meaning that these women are at increased risk of lymphedema. Lymphedema is typically identified when a patient or a care provider detects visible swelling in the upper extremity, but relying on this method exclusively can result in delayed diagnosis and treatment. It's very important to identify and treat lymphedema as soon as possible because more severe cases can be more difficult to manage. An ideal model of care to proactively detect and treat lymphedema is prospective surveillance. This involves preoperative and regular postoperative measurement of arm girth. This can be done using technology like a pyrometer or water displacement, but these methods are expensive and can only be administered by a clinician, so they're harder to access. To increase access to prospective surveillance for lymphedema, our research group developed an innovative self-measurement protocol where patients self-measure their arm using an inexpensive tape measure and stir stick. This method was shown to have high intra and inter-rater reliability, as well as high agreement with arm volume measured by a pyrometer. The figure here shows the mean difference between arm volume from the pyrometer and arm circumference from self-measurements, which are then converted to volume using a truncated comb formula. Overall, there was quite high agreement between the self-measurements and the pyrometer. The example here is from the affected arm of those who had lymphedema, with an average mean difference of about -8%. So with COVID, a public physiotherapy facility for after breast cancer surgery in BC went completely virtual, and they adopted our self-measurement protocol as part of standard of care. The purpose of this prospective study here is to evaluate the feasibility and acceptability of this protocol. So all patients who receive surgery for breast cancer at this site are mailed a self-measurement package about 1 to 2 weeks before surgery. This consists of an online video guide, a tape measure, a stir stick, and the flyer for the study. Patients are instructed to measure both arms at least once a month for the first 8 months after surgery, or whenever they notice a change in sensation or swelling in their arm. Self-measurements are done seated with the arm supported on a table, the shoulders flexed to about 30 degrees and the elbows flexed to about 45 degrees. Patients are instructed to measure at the wrist, as well as 10, 20, 30, and 40 centimeters proximal from the wrist. This is done on both sides, and patients are asked to compare between sides. They're instructed to call their physiotherapist if they notice more than a 1 centimeter difference on any measurement point between arms and or a change in sensation or swelling. They are then brought in for in-person treatments if needed. After surgery, people receive post-operative physiotherapy appointments at 1, 6, and 12 months after surgery. Here, the physiotherapist reviews patient self-measurements as well as any signs and symptoms. So again, all patients that go through this site go through these 3 steps, and then people who are interested in the study are asked for consent to contact by one of the physiotherapists at the site. We then email them the consent form as well as the study surveys, and we extract their clinical data once they are done the study. People are eligible to take part if they've had surgery for breast cancer at this site, can understand and communicate in English, and are able to use the internet to view the video guide. So main outcome measures include feasibility, which is assessed by looking at the number of patients who receive and use the self-measurement package, call the physiotherapist based on their self-measurement, and have accurate self-measurements based on a gold standard parameter. Acceptability outcomes include usefulness and ease of use of the protocol, patients' confidence in performing self-measurements, and the ability of the self-measurement protocol to decrease any worry or anxiety they may have about their breast cancer diagnosis or treatment. Exploratory outcomes include upper body function, which is assessed using the quick dash, anxiety and depression, which is assessed using the hospital anxiety and depression scale, and perceived health status, which is assessed using the EQ-5D-5L outcome measure. Acceptability and exploratory outcomes are assessed at 1, 6, and 12 months after surgery, and I'll be sharing preliminary results from the 1 month period here. So far we've had consent to contact from 64 participants, of which 50 have been enrolled in the study. Currently, we've had 21 people complete their 1 month appointment and survey, so I'll be sharing their preliminary results here. All identified as women, were on average about 56 years old, residents of Fraser Health Authority in BC, and most had received unilateral surgery for breast cancer. So for acceptability outcomes of these 21 people, the majority rated the self-measurement protocol moderately useful to use and moderately easy to use. However, most people rated their confidence as being slightly confident in performing their self-measurements. And this graph here shows that most people didn't feel strongly that the self-measurement protocol helped decrease any worry or anxiety they might be having. For preliminary exploratory outcomes, most people had fairly high upper body function. This was assessed using the quick dash, with scores ranging from 0 to 100 and higher scores indicating lower function. And as you can see here, the average quick dash score was about 27. Similarly, most people had low levels of anxiety and depression. Both were under the cutoff score for these constructs, which is 8 on the hospital anxiety and depression scale. Lastly, most people had fairly high self-rated levels of health, again ranging from 0 to 100, with higher scores indicating higher health. The mean self-rated health level was 74. And lastly, most people weren't experiencing issues with mobility, self-care, usual activities, pain or discomfort, or anxiety and depression. So overall, the virtual self-measurement protocol was fairly useful and easy to use based on these preliminary data. However, people rated themselves as slightly confident in performing self-measurements and didn't feel strongly that the protocol helped to decrease any worry or anxiety. These 2 points suggest a need for increased education and support throughout the post-operative period for these patients. So for next steps, recruitment is still ongoing and data collection is expected to continue into 2022. Besides having more people in the study, it's very important to have a more diverse sample, so including those with lower function and higher levels of anxiety to see how the protocol performs for them. And we will be doing prospective follow-up at 6 and 12 months after surgery for all participants. The overall aim of this work is to inform an approach to developing and testing models of physiotherapy care for after surgery for breast cancer to help overcome barriers to accessing physiotherapy services like geography and lack of trained therapists. This can help ensure individuals receive the right care at the right time and decrease their risk of lymphedema and other upper body issues. Thank you so much for your attention, and thank you to the rest of the study team. Happy to answer any questions.
Greetings to all conference attendees. I am Elizabeth Anderson. Thank you for attending this presentation of our study entitled Exploring Challenges and Creativity in Self-Managing Breast Cancer-Related Lymphedema and Work by U.S. Hispanic and Latina Survivors, a case study approach using photo-elicitation. I would like to acknowledge the grant support for this work. Dr. Armour and I have no disclosures to report. Currently, 3.8 million women in the U.S. are living with a breast cancer diagnosis. Increased survivorship is related to the advances in treatment and improved management of treatment side effects over the last 40+ years. Breast cancer-related lymphedema, or BCRL, is a cancer treatment sequela resulting from damage to the lymphatic system. It is the leading cause of secondary lymphedema in the U.S. Currently, there is no cure for BCRL. Surgical microsurgery continues to advance in treatment effectiveness for a small cohort of survivors, but the gold standard for treatment remains complete decongestive therapy. Research over the last 15 years has sought to illuminate the impact that BCRL self-management can have on work activities. Activities such as compression garment wear can impact workability, while work requirements can impact the time available for survivors to engage in self-management activities, such as exercises and home compression pump use. Need to prevent injury can necessitate a change in work performance. Lack of education for the survivor about self-management adaptations and return to work challenges can contribute to survivorship stress and negatively impact quality of life. Hispanic and Latino survivors make up over 15% of the 3.8 million U.S. breast cancer survivors. The literature has demonstrated that Hispanic and Latina survivors are at greater risk of developing BCRL. Factors such as level of acculturation, higher body mass index rates, and higher incidence of diagnosis with late-stage disease contribute to this increased risk. Greater understanding of the cultural influences on health behaviors is needed to optimize survivor care and outcomes. The purpose of this ethnographic case study was to explore the impact of BCRL self-management on work for Hispanic and Latina breast cancer survivors. The study incorporated data from 3 sources: a secondary analysis of a Hispanic Latina return to work origin study focused on work experiences while living with BCRL. A photo-elicitation interview explored BCRL self-management and work impact change and reciprocity through 23 participant-generated photographs and captions and a semi-structured interview. Ethnographic observation field notes described the experience of lymphedema care in 2 clinic settings. 89 hours of observation was completed. 2 lymphedema therapy clinics in a South Texas metropolitan area were the settings for this study. Origin study recruitment occurred between March of 2019 and October of 2020. The PEI was completed in October of 2020, and field observations occurred between November of 2019 and 2020. Propulsive sampling was completed with the assistance of a key informant at the lymphedema therapy clinics. Data analysis was completed using deduced qualitative analytic software. PEI analysis was completed by listening to the interview audio recording while following the written transcript and examining the photographs. I applied the descriptive codes from the secondary analysis as a starting point and modified the codes as PEI analysis progressed. Finally, I triangulated the themes from the secondary analysis, PEI, and field notes to determine where the theme patterns converged. The PEI theme of challenges of living alone integrated the secondary analysis themes of importance of support relationships and family adaptation. The PEI theme of adaptive creativity integrated the secondary analysis themes of obstacles and importance of support relationships. Historia is a self-chosen modified pseudonym chosen for privacy. Prior to breast cancer diagnosis, she worked for a rug company performing hand-sewn repairs. She was diagnosed with left breast cancer 18 years ago and received chemotherapy and breast radiation treatments. Several years after developing BCRL, she was diagnosed with peripheral neuropathy secondary to treatment-related brachial plexus damage. Living alone since her mother died in 2019, Historia has cats and a dog she sees as her familia as well as a sister and niece who occasionally help her with daily work and self-management activities. The first integrated theme is titled Challenges of Living Alone. Historia identified safety as a challenge. She expressed, "I wish I had a third arm," when discussing work with BCRL. The BCRL, combined with the comorbidity of peripheral neuropathy, required her to adapt her work activities, such as opening a can of pet food. As she described, she needed to get the can open while keeping her compression sleeve clean. Caring for familia is one of Historia's work priorities. The concept of familia has been documented in the literature as an aspect of Hispanic Latino culture. For Historia, this focus is her cats and dog. Clearing the litter box is a weekly event and one she has to learn to do by herself, as family and friends were not always available to assist. Next, navigating work obstacles is a daily event for Historia. She expressed, "You have to learn to live with it." She experienced a BCRL exacerbation, requiring a turn to compression bandaging. Her nephew had purchased this classic car, which she loved, and equated the bandaging with going back to the beginning, like the car. The second integrated theme is titled Adaptive Creativity. Self-management requires creative adaptation of daily work and care behaviors to optimize function and quality of life. As Historia describes, self-management requires think before you do. The hot summer months require a lot of creativity to enable survivors to continue to wear compression garments to prevent BCRL exacerbation and continue to work. Historia developed irritation at the top of her arm from the silicone band used to keep her compression sleeve in place. To keep wearing the sleeve, she chose to turn the sleeve inside out to keep the adhesive away from her skin. In addition, Historia had to find ways to minimize axillary irritation caused by the swelling. She and her sister decided to try to use a swim float in her favorite color to cope with axilla irritation. With breast cancer survivors living longer, the need to address work issues is critical to optimizing quality of life. As work changes over a lifetime, support needs will change. Incorporating assessment of work values and behaviors should be part of the care plan. This research can support individualized, culturally tailored goals for Hispanic and Latina survivors to build sustainable, flexible work plans. In addition, assessing BCRL self-management behaviors for each survivor is vital to lifelong prevention of complications and support of positive patient outcomes. Finally, this research contributes to the body of knowledge about the Hispanic and Latina experience with BCRL and work activities, which can help with successful behavior intervention development. Thank you.